Good morning, everyone, and welcome, and thank you for joining us today for another APSAD Insight webinar. My name is Tracy, and I'm a nurse educator here at Insight. Before we begin, I would like to acknowledge the traditional owners and custodians on the land on which we are presenting today. So for us here, that is the Yagara and Turrbal people. I would also like to pay my respect to elders past, present and emerging, and I'd also like to extend that respect to any Aboriginal or Torres Strait Islander people who might be joining us today. So as I am sure you're all aware from our program, we have Dr. Joss O'Loan joining us today to talk about his Hep C treatment and how, about Hep C treatment, not necessarily yours, but how you're rolling it out and how your team is bringing all the essential elements of testing, treatment and cure to marginalised and homeless people through a laid back approach involving a combi van and colourful shirts that it makes everyone feel welcome. So just before I do hand over to Joss, though, a little bit of housekeeping. I think most people are quite comfortable with Zoom these days, but if you have any issues, let us know by using the chat function and we'll attempt to assist. Likewise, if you've got any questions, pop them in the chat and we'll get to them at the end. And that's it for me. So I'm going to hand over to Joss now.
Beauty. Thanks very much, guys. Real pleasure to be here and present on the Insight series. You know, watch a lot of these and they're always great content. So I hope I can live up to the expectations. Also just reciprocate in terms of my acknowledgement of country. I'm too in Brisbane or Minjin on Turrbal Yagara land. So pay my respects to the elders past, present and emerging. And also I guess acknowledge that in terms of the subject we're talking about today, which is hepatitis C, you know, First Nations people are predominant in the numbers and the statistics of people that having hepatitis C, so acknowledgement of that as well. Today, we've got a bit of time, we've got about an hour, which is great. So what I thought we'd sort of discuss is the why, you know, treat Hep C, the how to treat Hep C, and then the what we're doing in terms of treatment Hep C, and sort of trying to get a bit of a discussion around what you can do in your clinic, in your environment, and in your workforce around Hep C treatment, screening and care. You know, I appreciate speaking to a large sort of audience here, you know, lots of doctors, nurses, social workers, psychologists and everyone in between. And I guess probably from the get-go, hepatitis C is not a doctor-only kind of issue. You know, it's an everyone issue. And I think, you know, we're going to get to that road of elimination once everyone sort of, you know, grabs a hold of it, regardless of what their job title is or what the name badge says. And I think that's, you know, it's a really team approach. So hopefully we get a bit out of it and move through. Couldn't do what we do without some help from our mates, and we've got some really good mates on board. And always need to shout out to John Conroy Classic Cars. They're the blokes that keep Lucy, our 1975 yellow combi van, on the road. So shout out to John Conroy. In terms of the you know, where are we and what's the picture of hepatitis C for those that aren't aware of what's going on. So I thought I'd, you know, do a bit of a backstory. We're fairly down the road in terms of Hep C elimination. In Queensland or in Australia, there's about 120,000 people. We've done a good job in terms of treatment for a large proportion of those, but we've still got about 50% of those people who had Hep C in 2015 left to treat. So the new treatment, the new DAA, the revolution of Hep C came out around 2015, 2016. We did a great deal of treatment then. We've still got a lot of people still we need to get on and treat for hepatitis C. Around 80% of people who have Hep C have that through injecting drugs. And probably really importantly, about 1 in 5 people don't know that they've got Hep C, which is quite a staggering statistic when you think about it. So we really need to go out and find, you know, the remaining 20% and you know, engage the, you know, everyone in terms of getting on and getting treatment for Hep C. Queensland, you know, we've got our lion's share left to do. So 43,000 people walking around with a virus that can potentially kill them. And also, you know, a virus which is infectious and they're passing on. You know, so in the sort of the COVID kind of issue, if we said that, people would, you know, massive alarm bells and things were ringing. You know, we've got an effective virus that can kill people, and 43,000 in Queensland. So it's really urgent that we get on it. A couple of bar graphs and statistics to hopefully not bore you all to death. But where is Queensland and how are we running? Okay, but not the best. We're down the back of the pack in terms of other states and other territories. And so probably the last line in this bar graph is the treatment uptake. And that's probably the important one to look at, which basically shows that one third of patients requiring treatment have started treatment in 2019. And it hasn't changed a great deal in that time. There hasn't been a massive uprush. The other thing to look at is we're below the national average in terms of our treatment. So the national average is about 40% of people needing treatment have got treatment. We're quite a bit below that. So in Queensland, if we're going to do our part to eliminate Hep C, we need to pick up the game. And being a proud Queenslander, I think we can probably lead the charge and really take over and be the first state to eliminate hepatitis C. And why can't we? It's just going to be a bit of grease, a bit of muscle power, and we'll get there. Zooming down a little bit more, I appreciate this sort of goes out, Queensland wide. And so where are you in your regions and how are we doing? So if Queensland average is 35, national average is about 40. There's some areas doing fantastic jobs and other areas that sort of need to sort of move along, I guess, to put it in that regard. Albeit, each different geographical area has their own problem, own challenge to overcome. But everyone needs to get to that 100% mark to call it elimination. Again, just drilling down, I won't sort of go too far into these, but for some areas, different drug and alcohol clinics on the north side or south side or Gold Coast, where are you guys at? And this is really great data from the Burnett and the Kirby Institute that really drill it down to postcode, which is quite amazing. So you can see that different AODs and different clinics and different doctors and different nurses can really have an impact on their local environment. So again, looking a bit further afield and seeing how we're going. So some areas doing fantastically, some need to sort of move along. This is a graph that some of you may have seen in the past, and it tells a few stories. And I guess the really important story that it tells is that we've got a lot of work to do. We've done some great work when Hep DAA therapy came out in the 2016 mark, and we treated a lot of people. But over the time, those numbers have started decreasing in terms of how many people are starting Hep C therapy, and therefore how many people are getting cured. And we need to pick that number up, because what we know is if we just tap along and do sort of the bare minimum, the virus is going to continually circulate. People are going to get reinfected, new infections are going to come about, and we'll never get ahead of the curve, again, to use some COVID sort of terminology. So by picking up that pace and picking up that treatment strategy, we'll eliminate Hep C and the hard work will be done. And that's, again, not to press the point, but really what we're talking about. We're talking about eliminating a virus that hasn't been done in many times in the past in medical history. But really, we're in the grasp of, in the next 10 years, on the precipice of eliminating hepatitis C, but we need to do some more work. So the takeaway from this graph is, how do we engage people that haven't otherwise been engaged in services to make sure that they get on, they get tested, they get screened, and they get cured for Hep C? And again, it's everyone's responsibility. This is a same graph, but presented differently, and really sort of highlighting that point of everyone's responsibility. So this is 100% across the top rather than numbers, and it's showing who's doing the prescribing and who are the people that are writing the scripts for Hep C. So there's a lot of GPs. So, in the first quarter of 2020, around 50% of people writing scripts were GPs, and the other were continuing specialists, as well as other unknown prescribers. So that's sort of interns or registrars in hospital settings and whatnot. So this, again, what's the take-home message from this graph? It really shows that hospital-based Hep C treatment is not a thing anymore. Community-based treatment is the norm and needs to be the norm if we're going to reach patients with Hep C. The old days of yep, you got Hep C, how about you go and see the gastros in the hospital? Sure, that's a step you can take, but really we need to be focusing on how do we reduce the barriers to access care, and how do we get people on treatment where they are and in the community, And it's great to see that people are doing it, as we can see. We just need to get more and more new prescribers, new GPs, new doctors, new addiction specialists, and new nurse practitioners writing the scripts. But we'll get there. Optimism. The why should we do it? And this is a really telling graph, I think, about, well, what has the change occurred so far? So as I said, in 2015, 2016 is when these medications came about. And what we can see once these medications came on board, a dramatic drop-off in end-stage liver disease, decompensated cirrhosis, hepatocellular carcinoma, and liver-related deaths. So you can clearly see, and after just a couple of years, that these medications, these treatment options, are dramatically reducing death and morbidity and mortality in our patients. So that's an amazing thing. And I think that's something that we need to highlight. Another one of, well, why should I do it? If that doesn't stir you up, the fact you're saving lives, if you're a guidelines kind of person, it's in the guidelines. So if you follow the book, well, follow the book and treat out of the book. So hopefully that sort of put a bit of context about why you should do it, and hopefully it sort of sparked the idea of, well, what can I do and how do I do it? As Shannon Knoll would have sung, what about me? What can I do? And for people that are up and running with Hep C treatment already, we're going to, hopefully this will be a bit of a refresh. For those that don't or haven't prescribed or are a bit unsure, we're going to run through a few of the sort of the points and markers about it. So one aspect that a lot of people say is, well, how do I engage with my patients? How do I ensure that Hep C becomes part of my care? And it really needs to come down to routine. Make Hep C screening part of your initial consults, part of your routine consults. And remember that 1 in 5 don't know they've got it. And so, if you're sitting in an AODS clinic, seeing someone for methadone or Suboxone, there's a high chance that they're going to have hepatitis C. Getting on the front foot in that first consult and discussing Hep C, offering treatment, offering testing and discussing treatment is really important. And it's one of those things, if it becomes a routine thing, you do it for everyone. Drug and alcohol presentations, is an obvious kind of part. But that sort of also includes, mental health presentations, sexual health, presentations, opportunistically as well. So if you're aware of people's risk behaviours, getting on the front foot as well and sort of springing it forward. People in jail, people recently released from jail are all risk factors. Emergency department presentations is another great spot to catch people and get that blood test. Because often it's that blood test that can be a bit hard to come by. If you're in an ED department, there's needles everywhere. Bloods are going off for all manners of reasons, and trying to engage them and put a Hep C treatment or Hep C blood test on that is a really good opportunity. How to engage? Some really successful sort of campaigns, start, as a grassroots issue. So, in your clinics and drug and alcohol clinics or wherever you're working, nominate a doctor, a nurse, a social worker, a psychologist, a caseworker, whoever it may be, and get them to be the champion for hepatitis C. Have someone whose key role it is to eliminate Hep C from your practice. Normalise screening as well. This is something we do for everyone. Hold events, have signs up in the waiting room or plaster around in the surgeries and the offices and say, look, this is what we're going to do. Open, non-judgmental environment is really important. We know stigma is a really massive issue in terms of people accessing care, including even in drug and alcohol settings. Discussing hepatitis C can often have a big stigma associated with it. The other important one is linking with your local networks. So there's some great local networks, some great sexual health clinics and gastro clinics, and often the CNC or whoever it may be at your local hospital. Is a wealth of knowledge and all too keen to help you start treating in your own environment, because that means less workflow for them down the line. A couple of other places, Hepatitis Queensland, again, a wealth of knowledge, and ASHM is a really good organisation for professional development in this space. Auditing practice data. So again, what I found in terms of my treatment is we've already done the blood test, we've already got the results. It's often that those results go unknowing or unactioned for quite some time. And even by simply doing just an audit of your patient cohort, finding out who's already had bloods, chasing those patients up and linking in those. And that's as simple as getting a list of your methadone or Suboxone clients or patients, and just going through their blood work and finding out who's Hep C positive, who hasn't had a test, and who's at risk of going through. That job's been made easier, I guess, but also therefore means a bit more cumbersome. There's a wealth of data now with the viewer linking up all pathology, jail records as well, and private pathology companies means that it is a bit of a phone legwork to try and get some of those informations. But again, it can be really important to get that diagnosis and get people on treatment. And often that blood test is the missing link. So that's the sort of how do you engage. And I guess hopefully as we sort of walk through this talk, the next part is standing on the outside looking in, as Chisel would say, where do we start and how do we get Hep C? How do I prescribe Hep C meds? How do I save lives? How do I reduce hepatocellular carcinoma, cirrhosis in my patients? So we're going to run through some ASHM slides, and these are sort of heavily borrowed, but I've changed them around a bit. So if you've seen ASHM talks, you'll probably recognise a few of these. So when to test, clinical indicators is a fairly good guide. Presence of risk factors. So that the top ones would be injecting drug users and sharing equipment, dodgy tattoos, and time in prison. They're sort of the three main ones that stick in my head. But of course, there are other aspects that you need to think about. And I guess that's the main point to say, if you think it, do it. And other people, obviously if they come in asking for a test, and in terms of sexual health screening or PrEP or those kind of things, I think it's an important thing to talk about bloodborne viruses in general. On Kombi Clinic and at Medico, where I work, we take a far simpler approach. If you've got a Neil Young, AC/DC or Red Hot Chili Peppers album in your CD player or your record player or Spotify playlist, whichever the case may be, you're probably primed for a Hep C test. What are the processes and what are the steps that you need to do to move forward and diagnose? There's sort of three things you need to think about. Do they have the virus? What's that virus done to their liver? And what else is going on in their life in terms of other factors? And that's pretty much it. Do they have it? Has it done any damage? And what else is going on? So a fairly simple process. So the blood test, the starting point. So this is a fairly stock standard blood screen that I would do. A couple of points I would probably make from this is the way that you write your form is really important. Trying to get one draw of blood and one draw only, the patient will thank you. If you get a bit of blood test and send them off again and again and again, they probably won't get the second or third, so you won't get the full information. The way that you get RNA levels after the antibody is just doing what I write is hepatitis C antibodies plus or minus RNA level plus Hep C genotype. And what that tells the phlebotomist is that they might be doing a viral load, which needs its own tube, so they'll pull an extra tube off when they're taking the bloods. And once it gets to the lab will run the antibody. If the antibody's negative, stops there. If the antibody for Hep C is positive, they've then got the blood test to go on to do the viral load or the genotype. And that means that speeds up the whole process, means you get all the information from one blood draw, because that can often be a challenging thing. And of course, looking at Hep B, HIV, and you want to know a few other factors around liver disease. To sort of bastardize a quote, you'll miss 100% of patients that you don't screen. So everyone you don't screen, you won't know. So again, make it standardized, make it commonplace and normalize Hep C screening. Really important take-home message that I guess most of people would get across this, but it's just around how do you diagnose Hep C. So this is a really great slide. Antibody means that have they ever come in contact with hepatitis C? and RNA means that they're infected now. So if you're antibody positive and RNA positive, you've got the disease, i.e. you need to go on and get treated. If you're antibody positive and RNA negative, means you were infected at some point. We know about 20% or thereabouts of people who have had Hep C will cure themselves without the requirement of treatment. And also the other great thing with DAA therapies on board, a lot of people have been treated. So we know that antibody positive, RNA negative, you had the disease. You then assess risk factors, ongoing injecting behaviour, screen regularly every 6 to 12 months. And antibody negative, never come in contact. So that's an important screen. So we worked out whether they've got it and whether they don't. If they do have the virus, Hep C, obviously Hep C impacts on their liver. We want to know how much liver damage has been done. And by that, we look at the whole picture. Yeah, there's not one thing that is going to tell us, but there kind of is. So, looking at the patient, if they're obviously jaundice, ascites, and encephalopathic, they've probably got some liver disease despite an EBI all over the shop. But, looking at blood tests, a really simple blood test to look at hepatitis C liver damage is what's called an ARPRI score. If you're less than 1 on your ARPRI, and I'll go and explain what that means, it's really unlikely that they've got cirrhosis. And so you can crack on and treat. If they're greater than 1 for their ARPRI, then it doesn't necessarily mean they have cirrhosis. It just means you need to go on and do some more investigations. And Fibroscan or shear wave elastography is the imaging modality of choice for that. So what's his ARPRI malarkey? So it's looking at your AST, so the patient's level over the normal upper level and the platelets. So it's a little equation that you can do. Really important, really simple and validated screening method for fibrosis and cirrhosis. And this is what it looks like. So that QR code there, so everyone loves a QR code these days. And I've got a couple throughout the presentation. So this QR code, if you scan it, will go straight to the website and you'll be able to plug in an ARPRI on there. And so what I do, I've got it on my Windows, on my desktop, internet browser as a saved place and just plug it in for that way. And again, greater than 1, need further imaging, less than 1, unlikely to have cirrhosis and treatment can initiate without further imaging. If you do need further imaging, Fibroscan is the brand name and Fibroscan is what people will sort of bang around. It's ultrasound waves being shot through the liver and assessing for stiffness. If you don't have access to a Fibroscan, if you don't have one in your clinic, which most people won't, there's ways to get that test. So a lot of hospitals in the southeast corner of Queensland anyway will do sort of a rapid in and out testing Fibroscan. So you can just send a patient off to the hospital just for a Fibroscan, which is pretty great. Again, link in with your local networks. I'll tell you how it works. There are a couple of roving Fibroscans. So on Kombi Clinic, we've got one. Hepatitis Queensland have one. ECCQ have one. So there's a couple roaming around, again, southeast Queensland. If you can't do that, the other option is your local radiologist or radiography company, and they can do what's called an elastography. And elastography is the umbrella term for Fibroscan. They'll do it on their machine, but they'll give you an answer back. It's an ultrasound of the liver, and then you just write plus elastography on it, and they'll then know to do the equations with the nodules and all that kind of stuff, whatever. So you get a result that way. So that's how you work someone up. What's the treatment? Really dead simple. There's 2 drugs for a disease. Both medications are fantastic in terms of side effect profile, pills only, short profile of treatment, and success rates. So all medications bandy around that 95, 97% cure rate. And you think about hepatitis C and having 2 drugs and other diseases. It's dead simple. So we just need to crack on. Important thing to say is they're pangenotypic. So genotype, although I'll often ask for it on a blood test, is not really it's not required prior to starting treatment, because these medications will treat any genotype and the treatment length is the same. The vast majority of patients that you're seeing will be non-cirrhotic, and you're really there left with an 8-week course with Maverick, 3 pills a day, the same time of day with a bit of food, or a 12-week course for Epclusa for 3 months. Pretty dead simple. Drug-drug interactions is an important one to think about. There's a couple of little key things. Statins and PPIs are probably the most common medications, PPIs being sort of symptomatically the most common medication to deal with. Again, really great website. You plug it all in, and that's a QR code that will go to the Uni of Liverpool website, and you just pop it all in. So really easy to use. Then you write the script. You call up PBS and stay on hold for 5 minutes and listen to the music, get the little code, and off you go. The things that I bang on with my patients about: compliance, drug interactions, compliance, and organised follow-up. So, compliance is really important. We know these pills work, but patients need to take them. When to phone a friend, when to refer on, when to have a chat with a specialist. Advanced fibrosis or cirrhosis. So that's, do you need a Fibroscan, or is the Fibroscan level above? Other extrahepatic manifestations, comorbidities, renal impairment, Hep C with HIV or Hep B. And if they've failed the first time around, that's probably a time to have a chat with a gastro or an ID in your local area. Monitoring and follow-up, really simple. There's no on-treatment monitoring. Phone calls and touching base and making sure compliance is working is probably the most important thing to do. In practical sense, what does that mean for me? I think it's really great and really opportunistically when you're talking about methadone or Suboxone prescribing or other issues, that you can say, oh, now how's the meds going for Hep C? Yep, great, awesome, fantastic. Or iron out the details through that way. And that's sort of how I do it. The other one is with the advent of telehealth, means that when I prescribe a medication, I'll book in a telehealth in a month's time to make sure that things are up and running and going smoothly. But apart from that, there's no blood tests to pull or anything. How do you confirm a cure? And that's the great part, telling someone they don't have a fatal viral disease. You do a blood test 12 weeks after the last pill that they've taken, and that's called SVR12. If they're negative on that, they're cured, don't have it, and they can go on and live their life. It doesn't mean they're immune, so that's the important thing to press. So if they are still injecting or go back into jail or whatever it may be, making sure that you're retesting for reinfection. If you get a reinfection, that's not, you treat that as a new novel disease because you've cured it, they've got the virus back again. That's not a failure of DAA. It's also important to note, as we said earlier, Hep C antibody will always remain positive after a cure, and it's the Hep C RNA or PCR, which is what we want to go on. I know I speak fast and shoot through that, and some people go, what? So again, QR codes are essential. So this one takes you to an Ashen 2-pager, or hopefully it does, hopefully its link's not broken, which sort of explains it probably better than I just did then. So in the last little while, talk about a bit of what we do on Kombi, what we've managed to achieve in our GP practice here, and look at models of care for success, as Bob Dylan would write it. So Medico and Arla is where I work, is my usual day job. So we're a suburban GP practice in Arla, which many of you will know, about 20 k's out of town, 5 GPs, and lots of, given the demographic of where we are, many patients injecting drugs. Myself and Matt Young, one of the other GPs, do QATP here, and we sort of fluctuate, but have around 200, 250 patients on methadone program, between us, half-half. So that's sort of the demographic. Back in 2016, 2017, we came up with the idea, the novel idea, how about we venture to eliminate hepatitis C from our little patch, micro elimination. So again, we did all those things we talked about earlier on. We normalised it, we had screening days, we made sure that every patient at risk left with a QML pathology form, And every time we had that conversation and we didn't have those bloods, we made that a doctor priority to really hammer that home. We had 226 Hep C antibody positives, 38 resolved spontaneously, had no treatment. So we had 188 Hep C RNA positives. Of those, 25 we referred on to tertiary care, 133 were treated by us. 30 were lost, jailed, moved to a different GP, couldn't engage them again to get treatment. So of those 133, we got 117 cures, which is fantastic. 10 were lost to follow-up, 4 failures due to non-compliance, and 2 reinfections. So I guess, again, what does this data show? It shows that a couple of numpty GPs in Anala can micro-eliminate their Hep C pool from their area. And without any sort of special technology or forms or anything along those lines. It's easy, it's accessible, and in terms of community care or primary care, the vast majority of patients are suited to be treated in primary care. So 85% didn't require any further investigations for cirrhosis, as they had ARPRIs below 1. There was no complications in terms of other viruses. And probably most importantly, in terms of a lot of this, there are patients and they trusted us. We weren't referring them off to the gastro unit or down the road or here, there and everywhere. A lot of the barriers to getting people onto treatment is around that trust, that doctor-patient relationship or doctor-nurse or however it is. That relationship that you build over time of seeing your patients enables you to bridge that gap and get them onto treatment. And that's a really important thing that you miss if you're just referring people on. So the learnings from that, as I said, simple, easy to be done in general practice or community care or drug and alcohol clinic or what it may be. And also extremely rewarding. The ability to tell someone that you don't have Hep C anymore is an amazing professional experience. I mean, it's amazing. I had patients in tears and people coming, bring their parents in, their wife, their husband in, just to let me tell them that they're not on Hep C. Because the stigma of hepatitis C is such an overarching thing in society that to say you don't have it is massive. But we also learned from treating it in our GP setting, there's a lot of barriers, largely social issues, around treatment of Hep C. Hep C is no longer a medical conundrum. As it was shown, it's a relatively straightforward, do a blood test, jump on pills sort of regime. But it's a social issue. It's a psychosocial challenge or puzzle that needs to be solved. And again, being a patient, or a doctor or a nurse that the patient trusts will break down a lot of those barriers. So one of the solutions that we came up with was we can't sit in our room and wait for people to come. We've got to go to them. So this Kombi solution was born. We need to simplify the process, break down those barriers of treatment. And we've been rocking around Southeast Queensland since about 2017. And we sort of run it out of our regular GP clinic. And people say, why do you have a Kombi clinic? Why is it a Kombi? And then, one of the answers is if you don't understand why a Kombi, you won't understand the question. But really, no one's going to get excited about a Toyota Hiace clinic, are they? So we had to have something iconic, something fun, and really we just want to drive a Kombi because it's awesome. Importantly, breaking down the barriers and then access to treat. Another thing that sort of got bandied around in my head and heard from a few conferences is the so-called hard to reach patient. And the way that I think about it, unless you're this bloke getting hung out of a helicopter picking up a patient in the back of Thargomindah, you don't have a hard to reach patient. You need to change the model of care that you provide for your patient rather than expect your patient to adapt to your model of care. And that's what ideally, health provision's about, isn't it? Providing the care that the patient needs, not the other way around. In many times it's the doctor, it's the script pad that's hard to reach. So how does it work? Well, like Gordy Tallis here, the Kombi Clinic grabs Hep C and flings it over the sideline. Another QR code. I didn't know how to embed videos and on a Zoom thing. So this is a little QR code that goes to a YouTube video showing what we do. So if you want to watch that later. We're at 1975 VW Kombi van, nicknamed Lucy Sunshine. We get a couple of RSEQ tow trucks on a regular basis. We bring out medical students, not for education purposes, but largely for push starts. And we have to park on a hill most days so we can, hill start it. And WA, workplace health and safety, we get lead levels every 4 weeks. Who's on the team? Matt, myself, fantastic nurse Mim, and an equally fantastic phlebotomist Mick Mooney. We wear loud Hawaiian shirts, laid back vibe, and play some awesome music. And again, another QR code. This one goes to a Spotify playlist. So if you want to set the vibe in your own clinic, get on this playlist and rock out. But as you can see, we're fairly approachable and go where patients are. So this picture here is us at MDC, which is the methadone dosing clinic in the Valley. We set up literally out the front of the clinic, and as patients walk in to get their methadone or their Suboxone, we say, hey, have you had a Hep C check? Would you like one? We can do one right here, right now. By the way, we can fibroscan you at the same time. So one-stop shop, bring it to where the patients are. Make it simple, make it fast. And just to highlight how simple the process is, these are a picture of my kids running through the process at a festival in Boovale, which we just set up in a park. And as patients come, we see them, we chat to them, get their bloods and do a fibroscan, organise follow-up. It's a one-step, two-step, three-step sort of approach in terms of how we do it. See them, bleed them, and organise follow-up. And then the third visit, we tell them that they're cured. Again, trying to streamline the approach as much as possible. We've now got it down to a sort of a two-step process. So in the first clinic, we can now use point of care testing, and I'll discuss that later in a bit, and give them a result in the same day and start them on treatment in the same day. So again, really simplifying the process. Where do we go and what's our demographic like? So anywhere and everywhere where patients that are underserved in terms of hepatitis C. So one of the locations on this that we've started recently going and haven't updated the graphics is probation parole officers as well. So what are our stats? Pretty good. Where do you think? Anyway, we're telling the story. But with a Hep C antibody rate of around 40%, we're hitting the right target. And we can get about 82% of people with Hep C RNA onto treatment that would have otherwise potentially not received treatment. To touch base on point of care testing, if the DAA therapy was the first revolution, point of care testing is the next. Some of you may have seen or heard of point of care and its different sort of manifestations. We've got a Genex Cepheid machine. It's fantastic. It can do an RNA Hep C viral load off a drop of blood of your finger, and you get a result back within an hour. So from the patient's point of view, it's nothing more cumbersome than basically a blood sugar. So it's a click on the finger. It's not a full bloods. We get a couple of drops and we can tell whether the patient has active disease or doesn't. And that's enough for us to initiate the treatment process. And patients love it. And I'm sure many of you have the approach of trying to get a patient who has horribly scarred veins to try and get a blood test, and it's really difficult. This cuts all that out. And the 1 hour approach means that you can do it same day as the patient's going off and seeing other people in your team, come back and give them results. Importantly, got TGA approved last year. So it's open slather in terms of treatment. How does it work? So this just sort of shows through where we go. So it really is just that drop of blood on your finger. Simplifying the process is what it's all about. So harping on that, making it, cutting out all the bits in the steps that you don't need. And again, another QR code going to another YouTube video. We're a bit camera shy on Kombi Clinic to see what we do. So we recently presented this at the INSU conference around some data that we had when we got the machine in December last year till May, so about 6 months. We tested about 300 patients, both in my GP clinic and out and about on Kombi. And we had about 15% RNA positivity, which is, so again, servicing the community that needs to be seen. And the important thing to say for this is that about 42% were started same day, able to give them the script same day. And within a week, 84% were started. So I'm sure a lot of you have similar issues in terms of loss to follow-up and tracking people down and all those kind of things. To be able to hand a script to someone there and then increases the likelihood they're going to fill the script, as opposed to letting them drift off and trying to catch up with them on a mobile phone that they no longer have at an address that they no longer live at. And just to show that we're not off on our own, hope that hasn't come through, probably has. There we go. Just show we're not off on our own. So this is a study from Kirkton Road in New South Wales, in Sydney, which I'm sure a lot of you guys know about Kirkton Road. And they did a similar study. They tested 100 patients, and what they found was, of those requiring treatment, 50% were able to start the same day, and the vast remainder on the days following. So really speeding up that process, simplifying that process, and getting things up and running. And this was done from a needle syringe program. And another, similar study done down in the Richmond, Melbourne supervised injecting room, using the Gen X machine. As patients came in to use the injecting room, they'd get have a chat, get screened, and then as they were exiting or the next day or when they saw them again, we're able to start them on treatment and cure them that way. So again, really similar patients and clients to what I imagine you guys are seeing. Patient reactions, so it's not all about stats and it's not all about numbers. So we sort of ask our patients, well, what do you reckon? And these are some of the responses we get. Gen X, how do you get one? So as I said, the revolution's here. It'd be a bit mean of me. I said, hey, these are great, and then not how to get it. So the Kirby Institute, bit of a plug for them, are rolling out this $6.5 million bonanza and going to put Gen X machines all throughout Australia. I know that Metro North, Metro South, I believe, have sort of signed up or somewhere along those lines. If you're keen in your area, David Silk, the project coordinator, give him a shout out. And they're sort of going to have a bit of a process in terms of where they're sending and all that kind of stuff. But if you're keen, link in with David. In terms of just wrapping up before we sort of close and do some questions, we've also hit corrections. And so we've done some treatment blitz and testing blitz, doing entire prison populations over just a couple of days, which is amazing. So we can eliminate hepatitis C from a high risk population group in prison just in a couple of days. And we're doing that in collaboration, of course, with Corrections, Queensland Health, Quinn and Hepatitis Queensland. This is a photo of our first one at Palin Creek, which is down near Rathdowney. Beautiful, beautiful place. And just a great couple of days testing, treating patients. We've got another QR code, sorry to flog you with those, but this is to a Spotify playlist to get that vibe right. And next week we're off to Lotus Glen. Mim has lined up a fantastic roadshow to screen and blitz Lotus Glen and get that up and running in terms of Hep C elimination. A couple of stats from where we've been. I need to update Lotus Glen, bit of COVID postponement, but that's next week. So in terms of wrapping up, and hopefully I've kept to time, look for opportunities, not barriers, in terms of rolling out a project like this in your area. Unbridled enthusiasm, meticulous planning, and adaptability trump all negativity. Hepatitis C is such an important disease to eliminate that there is no barrier that can't be broken. It's such an important thing to eliminate from your practice, for your patients, but also from a public health wise, that we really need to rock on and do it. And obviously when you rock up in a combi van wearing a floral shirt, cranking out some music, anything's achievable. Just finally leaving with a couple of years ago, pre-COVID, in the world of pre-COVID, we handed out disposable cameras to a lot of patients that we saw and said, tell us your Hep C journey. Again, statistics can mean a lot of things and graphs are great to present, but personal interactions are really what it's about. So we handed out these disposable cameras and said, take photos of what Hep C cure means to you. So this is what it was. Beauty, and that's the end of the presentation. So I'll open to any questions if anyone has it.
That was brilliant. Thanks, Josh. We do have a couple of questions. First one was, how do we sort of incentivize GPs to get on board with doing the testing and prescribing?
Great question. And so, oh, look, money talks, bullshit walks, is put it. But yeah, I mean, and that's a really good question. How do you employ a workforce that is basically private contractors? And money is a great example of how to incentivize it. You know, it's a bit of a shame that you need to pay people to do their job. But yeah, you don't need to pay people to do their job, I guess is the other way to put it. In New Zealand, they do have a project where they are paying GPs to diagnose and to get and work people up to screening. And I think that's, you know, 120 bucks per diagnosis or something along those lines. And so, yeah, making a new MBS item where you could then use that MBS code for every new diagnosis would automatically and overnight put it on the radar of every GP, wouldn't it? And it's
simple and easy, but it sounds simple, doesn't it? Yeah. And what about engaging the clients? I know just from my own clinical practice, trying to get a client to, you know, you talk about Hep C, you talk about bloodborne viruses and things like that. And, you know, we can do this test for you. We can check, you go through all of that and talk about it. And then they go, yeah, nah. Or you give them the path slip, but, you know, they go, oh, well, maybe you give them the path slip and they don't follow up. What's your way of sort of, I suppose, engaging the clients to go out and do that?
Yeah, really good question, because I think that gets to the crux of it, isn't it? So that's, you know, and that's the tricky bit, as I was sort of saying. So the medicine side, the medical side is a piece of piss. It's really easy to, once you've got that diagnosis, to move through, but how do you get that diagnosis? And that's the challenge. And that's, you know, the art of medicine as opposed to the science of medicine. And that's what it really comes down to. But a couple of things I think it's important to keep at the forefront of your mind is patient priorities. So what is their priority today and what's your priority? And making sure that you're ticking off patient priorities as well. And whether that's to get their methadone script and get out, or get their Centrelink script, or, you know, notes, or maybe it's something completely different, or maybe their home life is such chaotic scene that they can't think of anything more now than, well, how they're going to get food on the table and those kind of things. So I think, you know, coming about it holistically, trying to approach and give it a wraparound service is really important, and try and tick off the patient's agenda is an important thing to do. But at some time, and sometimes they're not all possible to tick off. You know, making sure that they know that it's up the top of your priority, and nag is one approach. Reducing the barriers so that it doesn't need to be up the priority. So, you know, bring in the phlebotomist to a clinic, do the bloods as you're sitting there now with them. So, I don't have time to do the bloods. Well, how about while I'm faxing off your methadone script to the chemist, I'll do your bloods, because that'll take 5 minutes, and, you know, you've got to sit around, you know. So coming up with those kind of solutions. We incentivize it on Kombi, so not in the GP clinic, but on Kombi van. So we give out $10 vouchers to encourage people, reimburse them for their time and their effort, which is, you know, and that's a way to help engage it, and, you know, again, alleviate some of those pressures that they're under.
That's great. I know too, also from my own practice, I've had clients that they'll know they're Hep C positive. They've already got that diagnosis, but they're reluctant to engage in treatment. And some of that's come from the old, you know, the stories from the old treatment, or maybe they've even gone through the sort of the older treatments. What sort of side effects are they getting from these new ones?
Yeah, so yeah, the legacy thinking, or the overhang from interferon, ribavirin A, it's, you know, really important up front to say completely different chalk and cheese. Yeah, this is nothing to do with that. You know, I sort of talk about horse and buggy technology and rocket ships. You know, so far apart. And so that's an important one to break down, because often, as you say, patients will have, when they're in jail, their mate was on the ribavirin and he went blah, 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 blah. So you've got to break that down early. Side effect profile from this is really minimal. So a bit of headache, bit of nausea, and that's largely it. The other thing it's important to press the point of is these are cancer preventing medications. And that's the other way that's important to sell it. So if you don't get treated with hepatitis C, there's a 1 in 3 shot, so rough numbers, 1 in 3 chance that you'll go on to have hepatocellular carcinoma. And I can tell you, mate, the treatment for that is a lot worse than this. So putting it in context of why they need to get treated is really important. The other aspect is Hep C, the virus. A lot of people go, well, I feel all right. I don't have a disease. Guarantee you treat them and they go, gee, I feel a lot better than I did then. I didn't realise how sluggish I felt, how fuzzy in the head I felt. I feel a lot more energetic. I've got my life back and all those kind of things. So I think pressing that point is also really important.
Yeah, cool. And you're saying too that, if they do become reinfected, that you can just do the treatment again. Is there limits to how many times they can do it, or has it become less effective or anything with retreatment?
Yeah, no, so that's a fantastic thing. In Australia, the way that it's set up is if it's a new infection, then you can just roll out the treatment again. And the expectation is that it's just as successful as the first time round. So, and again, that's an important thing to say to patients. So a lot of the patients I see, well, I won't do treatment now because I reckon, I've got court coming up and I think I'm going back in and I'll do it when I'm out, kind of thing. And to which I say, no, we'll treat you now. If you get it in jail, they'll treat you in jail. If you come out and you still have it, well, I'll treat you again. So that's an important thing to do, because it's, again, reducing the pool of hepatitis C in society. Means there's less likely people pick it up in jail. People say about the medication cost. So the way that the feds have linked up with the drug companies is that they're paying a subscription, not per bottle. So the sticker price is quite obscene when you look at it. The way the feds sort of linked in with AbbVie and Gilead and those people, they said, here's a whole lot of money, provide us with medications for X amount of years. So by retreating people, you're not dipping into the public purse more and more times because we've already paid for it. So that's
Cool. Got another one just come in, the RNA viral load. What is considered a high load, and does the load affect treatment?
No, is the short answer. So it used to. So back in Harvoni days, so that was a medication that was one of the first ones to come out. Then you could change your treatment around whether it was less than 6 million or greater than 6 million about treatment duration. But no, it doesn't. So, whatever the number is, if it's a lower number, it's likely that they've had hepatitis C for a shorter period of time. If it's a higher number, it's likely they've had it for a longer period of time. But it doesn't seem to be impactful on cure rates, the likelihood that they'll get cured.
Okay, cool. And one last one, how do you engage the historical injectors? So those that aren't currently accessing AOD treatments. Yeah,
really, really good question. And I guess, finding where people are. So I guess there's probably a couple of ways to go about that. There needs to be more coverage around hepatitis C in Australia. If you've ever, dabbled in your past, go and get tested. And try and get more GPs to include Hep C testing as part of a routine care, I think is really important. And decreasing that stigma, because obviously there's a lot of stigma. If you're 50 or 60 and you dabbled in your 20s and you've been seeing your GP on and off, it's hard to then go and say, hey, look, I dabbled, back in the day. I'm now a High Court judge or whatnot. Can you test me for Hep C? So it's about breaking down that stigma at a societal level, but also at a professional level, I think is important.
I think that stands true even just with current injectors. A lot of GPs, I know, talking to GPs as a clinician, they're quite shocked. Oh, no, they don't look like that. No, I don't think they inject. I'm really surprised. So there can be that sort of reluctance in current engagement for people to sort of say, I might be at risk.
Yeah, and I think you're right. It needs to be normalised and thought of as cancer screening. So, we do HPV screening for cancer prevention. We do, colorectal screens and all the rest of it. And really, hepatitis C is an easily tested for disease and an easily treated disease, and a disease that has significant consequences if left unchecked. So, we really need to have more screening in society, targeted and also global.